Greetings and welcome to the MHA Alumni Webinar. I am Megan Lafine, Assistant Director of Alumni Relations at the School of Public Health. Thank you to all alumni, students, and friends of the MHA program who have made time to join us live today. Today's webinar is hosted by the MHA Alumni Association and was planned by the MHA Education and Engagement Committee. We are excited to offer this webinar to encourage and provide lifelong learning to both local and distance alumni. We hope to offer more webinars in the future as part of an ongoing series. I'd like to thank the University of Minnesota Alumni Association for hosting this webinar on their platform. We are grateful for their partnership. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to listen over the telephone, just select Telephone in the audio panel of your GoToWebinar panel and dial-in information will be displayed. If you experience audio difficulties while listening via your computer speakers, this can be caused by having multiple software applications open, which can use up your computer's bandwidth and affect network performance. Listening in on a wireless signal may affect performance as well. Please feel free to close any unnecessary applications on your computer. We will welcome questions at the end. Please type your questions in the questions panel on your GoToWebinar control panel. We will monitor all questions and address them at the end. And now I would like to introduce the presenters of this webinar, Jean Abraham and Ann Carlson. Jean Abraham is the Wegmiller Professor and Master of Healthcare Administration Program Director in the Division of Health Policy and Management at the University of Minnesota School of Public Health. Dr. Abraham received her PhD in Public Policy Analysis and Management from Carnegie Mellon University. Her research areas include health economics and policy. She is particularly interested in employer and employee decision-making with respect to health insurance, employer wellness program evaluation, and competition in provider and insurance markets. For the 2008-2009 academic year, she served as a senior economist on health issues with the President's Council of Economic Advisors in Washington, D.C. Ann Carlson manages the Medicare product portfolio at Blue Cross Blue Shield of Minnesota. Prior to her current role, she served as a government programs consultant during the Blue Cross system platform transition. On behalf of United Healthcare and Retirement, Ann managed the relationship with AARP for AARP brand Medicare Part D plans. Later, she served as Director, Strategic Alliances and Business Development, where she led development and implementation of innovative services for Medicare plans members. Ann received a Master in Healthcare Administration from the University of Minnesota in 2010. Welcome, Jean and Ann.
Thank you very much. Good morning to everyone, and Ann and I are delighted to be here today to talk about the Affordable Care Act, past, present, and future. So today, over the next 45 minutes or so, we're going to summarize the objectives of the Affordable Care Act, or ACA. We'll present some evidence regarding its impact with a special focus on the individual market and the Medicaid expansion. And then we'll spend the remaining time discussing the future. So as we get started, let's take a brief trip back in time. So this chart represents the distribution of coverage as of 2009. In 2009, when President Obama first took office, we had a distribution of coverage in which about 56% of the population had employer-based insurance. Another 30% or so had either Medicare or Medicaid. 9% roughly had direct purchase or individual coverage, and about 17%, or about 50 million Americans, reported being uninsured. At that same time, this is what the spending trajectory looked like. This chart shows the national health care expenditures as a share of gross domestic product. And you can see here at the point of roughly 2008-2009, spending was expected to rise rapidly as a share of GDP. And as such, there was a keen interest among lawmakers to address the cost and affordability issues via reform. So under President Obama, when he came into office, there were two overarching health reform objectives put forth. The first of these was to reduce the number of uninsured Americans by expanding access. Many of the uninsured were in that position because of unaffordability, and some were uninsured because they couldn't qualify for public insurance or did not have access to employer-based coverage. Some individuals couldn't purchase insurance on their own because of pre-existing conditions. The second objective was to craft policies that would lead to genuine containment in the growth of healthcare costs vis-a-vis payment reform. So now I want to spend a few minutes talking about the successes and failures of the ACA as we know it through the evidence base. So first, let me begin with the young adult expansion of coverage. One of the most popular provisions on both sides of the political aisle is the expansion of dependent coverage eligibility to young adults until their 26th birthday. Although a number of states had passed similar provisions on their own, this was really the largest, grandest scale in terms of the federal level. This chart demonstrates the change in the percent of adults who were uninsured at the time of the interview, and you can see what has happened over the passage between 2010 to 2016. In 2010, at the height of the recession, the uninsured rate among 18 to 24-year-olds was over 30%. It fell over time to 13.7%, which is a sizable change. Some of this was due to the dependent coverage expansion, and some of it was due to macroeconomic recovery. The scholarly evidence that uses quite rigorous methods to model this change, accounting for lots of other factors, found that more than 1 million young adults gained coverage shortly after this particular eligibility expansion. The major coverage expansions occurred in 2014. One of these was through the Medicaid, or expansion of eligibility for Medicaid. In particular, for states that opted to expand Medicaid eligibility, they could do so by expanding the income threshold to individuals who were in families earning less than 138% of the federal poverty level. This was an option chosen by a number of states. And one of the main reasons for this was that it enabled, for states, it was beneficial because the federal government would pick up a much higher share of the costs for those newly eligible enrollees. In fact, they would pick up all of the cost for the first 3 years and scale down to 90% of those costs for 2020 and beyond. As of October 2016, this is the state of Medicaid expansion decisions. In particular, 32 states, including DC, expanded Medicaid, and this is noted in blue. The states that have chosen not to do so at this time are denoted in orange. The other key mechanism through which coverage expanded was through the introduction of premium tax credits and cost-sharing reduction subsidies for individual coverage that would be offered through newly created exchanges or marketplaces. Since 2014, the individual market has included the marketplace as well as the off-marketplace. States could choose to have their own marketplaces, or they could have the federal government provide some or all of the support. The ACA made a number of changes to the individual market, some of which will be discussed by Anne momentarily. Very briefly, the ACA on the demand side of the individual market made changes to what insurers could do around underwriting individuals based on their pre-existing conditions. It sought to change the way premiums were set by introducing modified community rating. And of course, it was the mechanism through which to extend subsidies to low-income Americans. There were also other changes to help the market run more effectively, including greater plan standardization and plan transparency. On the supply side of the market, there were also changes because, of course, the availability of subsidies and cost-sharing reductions enabled or was attractive to insurers who saw this as a potential growth area. There were also some mechanisms put in place, known as the 3 Rs, to help insurers adapt to this new market environment. These mechanisms were designed to help buffer or mitigate some of the potential risks that insurers might incur given the new rules. And finally, there was a desire to expand the number of insurers in the market to enhance competition and be able to reap some of those effects. So the punchline of the major coverage expansions was a reduction in the uninsurance rates. Here you can see that shortly after the passage of the ACA, the uninsurance rate was approximately 18.2% among the non-elderly population in the U.S., and this dropped to about 10% in 2016 based on survey data from the National Health Interview Survey. Now, it is important to note that, of course, some of this was due to the expansion provisions, and some of it was due to macroeconomic recovery. For healthcare providers, there were also benefits from the ACA. Notably, this has actually been an area of research by a number of health economists who were looking at what happened to the payer mix. Fred Blavin from the Urban Institute published a paper that showed that hospitals in states that had expanded Medicaid had a decrease in uncompensated care costs as a result of the expansion and an increase in the share of Medicaid revenues as well as operating margins. This work has been replicated and enhanced. Similar findings have been found by others as well as we think about hospital finances. Finally, of course, the ACA made investments in trying to develop new payment models, and this came through both CMS, the Centers for Medicare and Medicaid Services, and of course the Center for Medicare and Medicaid Innovation. Many of the payment model innovations are still in place, and there's been considerable learning that has resulted from them, including ACOs, accountable care organizations, bundled payments, and efforts to reduce readmissions. Finally, let me just briefly mention some of the work that I do. Clearly, one of the issues that was raised at the time the ACA was passed was the impact that the creation of new public insurance eligibility and a new individual market would have on employer-based insurance, which is the mechanism through which about half of the non-elderly population gets their coverage. Some work that I've completed with my colleagues revealed that the employer-based system of insurance remained quite stable. 95% of U.S. establishments either continued to offer or continued to not offer insurance between 2013 and 2014. Those that chose to drop insurance as a part of workers' compensation were mostly very small firms and low-wage firms. Current work that I'm doing is also not showing any negative effect of the Medicaid expansion on establishments' decisions to offer health insurance. Of course, there were some downsides to the ACA in this employer space. Two of them included the provision of the small employer tax credit to try to promote offers by small insurers, as well as the launch of the shop exchanges, which were analogous to the marketplaces for individual coverage. These were designed to help make shopping easier for small employers. So let me now go ahead and turn over the presentation to Anne, who will talk about the present and take a deeper dive into the individual market.
Thank you, Jean. Historically, the health insurance market where individuals without private or employer or public program coverage shopped was a residual market. That is, it was a last resort where people ended up when other options weren't available. The individual market resulted in high administrative expenses and represented 40% of the premium price. Insurance products were inconsistent in benefit designs, that is what was covered and to what degree. There was no product standardization or way to compare plans apples to apples while shopping. Individuals with a health condition could be denied coverage or have exclusions built into the benefit designs that would not cover services associated with the health condition. Just a quick note that there is limited research to understand individual market functioning because there's poor data and overall lack of data. Jean has introduced the context of the Affordable Care Act. Let's take a look at how the ACA is designed to work as it pertains to the individual market. There are 3 legs to the ACA, and I'm going to walk through those here just really quickly. The first leg comprises consumer protections that require insurance companies to sell their plans to everyone and that prohibit them from excluding coverage for pre-existing conditions or charging a higher premium to those who are sick. The second leg comprises making coverage affordable for individuals by providing financial assistance, federal premium and cost sharing subsidies, for those at the middle and lower ends of the income scale. And the third leg comprises a financial penalty, also known as the individual mandate, for those who can afford to get coverage but choose not to. All 3 legs directly or indirectly support increasing the number of healthy individuals participating in the ACA individual market exchange risk pool and help spread or share healthcare costs broadly. The higher the proportion of healthy individuals in the pool means increased financial stability and lower cost per capita. Now we're going to, Jean earlier had introduced the idea of the 3 R's, and we're going to take a look at those more closely here. The 3 R's are risk adjustment, reinsurance, and risk corridors. Together, these programs were designed to protect health insurers against unpredictable losses or unmanageable risk selection and keep premiums from spiraling in the first years of the Affordable Care Act's coverage provisions. Risk adjustment. Let's talk about that one. Though the ACA bans carriers from turning people down or charging them more based on their health, the incentive to attract healthier enrollees remains because healthier consumers increase profits by reducing companies' payouts. With healthier enrollees, plans can reduce premiums and maintain profit margins. This reinforces their advantage with healthy customers who are often most price sensitive. The result is an unstable market in which some plans experience a favorable cycle, attracting more and more good risks, and other plans a vicious cycle in which their higher risk enrollees and higher premiums make them less and less competitive. Risk adjustment interrupts the cycles. It adjusts for differences in health of plans enrollees by redistributing funds from companies with healthier than average customers to plans with sicker than average customers. Reinsurance. In the ACA individual markets, where insurers have to take all who apply regardless of health status, random occurrences such as having a high percentage of members experiencing catastrophic illnesses can make the difference between success and failure and between being able to keep premiums down or raising them dramatically. Reinsurance manages the risk by insuring health insurers against it, using fees collected from all the nation's health insurance companies, that insurance premiums paid by insurers. The federal government proposed to pay insurance plans 80% of the costs between $445,000 and $250,000 experienced by any of its enrollees in 2014. In 2015, the terms changed to 70% coverage for costs between $70,000 and $250,000. The temporary reinsurance program ended in 2016. It lowered marketplace premiums by as much as 14%. Minnesota, I'll talk about it a little later, but Minnesota recently passed a reinsurance program, and I'll go into that in greater detail later. Risk corridors. Profitable insurers pay funds into the program while plans with higher medical claims receive money. A similar risk corridor program exists with Medicare Part D. The federal government now owes more than $8 billion in payments to cover insurer losses on health insurance exchanges, and the industry is not feeling certain that the cost will ever be reimbursed by the government at this point. Some of the reforms, Jean introduced several of the reforms earlier, and I'm going to walk through them one by one with just a quick definition, and that way we've got the foundation for what we're going to cover going forward. The first reform is guaranteed issue, and that, of course, is that insurers are required to accept every individual and employer that applies for coverage. Waiting periods were removed. ACA prohibits insurers from imposing waiting periods for coverage that exceeds 90 days. Modified community rating. The ACA requires insurers to vary rates based on 4 factors only, and we'll talk about those in the next slide. Pre-existing condition exclusions. The ACA prohibits insurers from imposing pre-existing condition exclusions with respect to benefit designs and coverage. And then EHBs are essential health benefits. The ACA requires the ACA prohibits insurers from, the ACA requires coverage of certain benefits for 10 categories, and we'll talk about those in a few slides too. OPCs are out-of-pocket costs. The Affordable Care Act requires insurers to limit annual out-of-pocket costs, including co-pays, co-insurance, and deductibles, to the level established for the high deductible health plans that qualify as health savings accounts. And this indexes this level to the change in the cost of health insurance after 2014. And the last is actual value. The Affordable Care Act requires insurers to cover at least 60% of total costs under each plan. It requires plans to meet 1 or 4 actuarial value tiers, and you've heard of those: bronze, silver, gold, or platinum. We're going to take a quick look at modified community rating, which I referred to just a few minutes ago. It's modified community rating because it's not pure community rating for the ACA. The ACA requires insurers to vary rates based on the 4 factors you see here: family composition, geographic area, age, and tobacco use. Charging older adults in the oldest age band more than 3 times the rate of a younger person in the youngest rate band is prohibited. And insurers cannot charge tobacco users more than 1.5 times the rate of a non-tobacco user's rate. Higher than estimated proportions of individuals accessing care through the individual market exchanges are sicker and older. Insurers are facing challenges covering the costs of care for older individuals and less healthy individuals. This was not predicted. Let's take a look at what's been happening since the ACA was rolled out in 2014. In some geographic areas, insurers are exiting. Some areas in the country have a single insurer participating in the exchange. With respect to insurer participation in the marketplaces, 2014 had relatively modest participation among insurers. Many of the nationals stayed out the first year or dipped their toes in the water. 2015 saw more entry, including United Health Group. In 2016, insurers had rocky experiences and began to exit. In 2017, additional exits occurred, particularly within states with rural areas. Notable states are Arizona and Arkansas. The first 3 years were the additional projections, risk corridors, and reinsurance. Many insurers did not get risk corridor payments. In monopoly markets, Blue Cross Blue Shield has been the insurer in about 95% of those counties. Having multiple insurers selling coverage in local markets is very important. Research, including some by Jean and her colleagues, finds that each additional insurer in a local market is associated with premiums that are 4% lower on average, holding all else constant. Premiums and affordability have occupied the headlines. Here's a set of box and whiskers plots that summarize the distribution of second lowest silver plan or benchmark premiums offered in the geographic rating areas in states using the federally facilitated marketplace, which includes about 30 states. A silver plan has a 70% average value, which means that for a population, the benefit design means that the insurance will cover approximately 70% of total spending. What you see here is the monthly premium for a 27-year-old individual for the years 2015, 2016, and 2017. You can see that the median premium is rising over time. Variation in premiums is rising across geographic rating areas within a given year.
Okay, great. Very good. So Anne did a wonderful job of kind of summarizing the core tenets of the ACA, particularly with respect to the individual market and where things stand today in terms of insurer participation and premiums. I want to go ahead and move us forward and talk a little bit more now about the repeal and replace efforts. So clearly it's no surprise that the ACA has been a controversial piece of legislation since its passage in 2010, and Republicans have introduced legislation multiple times to repeal the ACA. If we look at polling of adults in the U.S., there's very much an even split in terms of favorability. In June of 2016, the House GOP generated a white paper called A Better Way to lay out their principles for reforming the U.S. healthcare system. This document included repealing the ACA as well as setting forth the principles of providing Americans with more choice, lower costs, protecting the vulnerable, spurring innovation, and protecting Medicare. On Election Day, Republicans won the White House and remained in control of Congress. This created a window of opportunity to act on the desire to repeal and replace the ACA. Although because of the particular composition in the Senate, any legislation would most likely need to be passed through budget reconciliation, similarly to how the ACA was passed in 2010. The Republicans faced a significant challenge in attempting to repeal and replace. That is, they wanted to maintain the principles of access, choice, and affordability, but in a way that is distinct from the ACA. The piece of legislation proposed, of course, was the American Health Care Act. With respect to the individual market, the AHCA included eliminating the current income-based subsidy system and replacing it with age-based tax credits. This represented a fundamental departure from the idea of redistributing resources through subsidies based on income or means to one that redistributed based on expected health spending as proxied by a person's age. Additionally, they sought to expand the age rating factors from 3 to 1, which is current practice under the ACA, and causing significant cross-subsidization from young people to older people. Finally, they sought to repeal standardization of the plan standardization of the metal levels of catastrophic, bronze, silver, gold, and platinum to allow more heterogeneity and differentiated plan designs. In lieu of an individual mandate, the AHCA included a continuous coverage incentive so that in order for individuals to not be able to game the system, that is jumping in and buying coverage when they became sick and then dumping it when they got better, individuals would face a 30% late enrollment surcharge for a plan year if they couldn't demonstrate having had coverage in the past 63 days. However, insurers could not underwrite on health status and would not be able to deny individuals based on pre-existing conditions. Finally, the Republican legislation also included funding to advocate for greater support for states around subsidizing high-risk individuals and restoring safety net funding. So the AHCA also proposed major changes to the Medicaid program, first enacted in 1965, and one of two programs through which coverage was expanded through the ACA. Medicaid is jointly funded by the states and federal government. States that are poorer, as captured by their per capita income, tend to get a higher share of federal dollars relative to wealthier states. This graph just shows you the distribution of the different types of enrollees in the Medicaid program and their corresponding expenditures. This chart comes from the 2016 actuarial report on the financial outlook for Medicaid. What you can see here on the left shows you the distribution of enrollees by type. So children represent 41% of all Medicaid enrollees, but constitute only 19% of spending. In contrast, persons with disabilities comprise 15% of enrollees and 40% of spending. So it's clearly not equal across the different groups. Here's another way to depict that. This is annual per enrollee spending for fiscal year 2015 for the different major categories of Medicaid enrollees. Here you can see that, again, children are the least costly, the disabled are the most costly on a per person basis, and the group that are newly eligible, the expansion adults, really sit in between with a per capita spending of about $6,360. So the AHCA had also proposed several additional changes to Medicaid, and I've listed these here. Notably, that would have repealed presumptive eligibility for Medicaid adults. It was going to repeal the state option to expand eligibility at the end of 2019, and it would have repealed the enhanced match rate for newly eligibles as of that date as well. So in essence, states who had expanded out would, for anyone new they wanted to expand, they would have been paying the full kind of state proportion as opposed to the enhanced match rate. Perhaps the most controversial piece of the proposed changes was around shifting Medicaid to a per capita allotment system beginning in fiscal year 2020. Here, the federal government would set a limit on how much to reimburse states per enrollee, and that would be specific to particular types of beneficiaries, but based upon what the world looked like in 2016, adjusted for inflation. This was really a fundamental change from the current form in which it's really not known with certainty what that federal and state share of spending, or I'm sorry, the state and federal amounts of spending will be year to year. In particular, some argue that that's actually, well, many argue that that's a real challenge long run for the federal budget. There's also some who would argue that that this type of arrangement gives states much more flexibility and the ability to become more innovative around how they spend those dollars. So this is not a new topic, and probably one that won't go away longer run. It will come back in future discussions, but for now it is quiet again. Finally, of course, as part of the AHCA and the repeal of many of the expansion provisions, including the premium tax credits, income-based credits, and cost-sharing reductions, the AHCA also sought to essentially remove most of the pay-fors that were included in the ACA and designed to help pay for the coverage expansion. This included the individual mandate, the large employer penalty, the fees on insurers, medical devices, and drug manufacturers, and some of the taxes levied on high-income earners. So the AHCA in mid-March, it was made public what the legislation included, and the Congressional Budget Office scored it about a week later. And when they scored this piece of legislation, it revealed that the number of uninsured individuals would rise up to 24 million by 2026, essentially offsetting most of the coverage gains and a bit more. They also modeled that individual market premiums would initially increase and then decrease because of who was actually buying individual coverage. So the result of that created quite a lot of media attention, and I think most of us are probably familiar with what happened from there. So I happen to be a political science major in undergrad and along with economics, and so this was a very intriguing time last month to watch what played out in terms of the politics of health reform. And what we know, of course, is that the Republicans faced a very difficult challenge to try to appease both the moderates in the House and the very fiscally conservative wings of the party. Additionally, we also have been hearing much about town halls as members of Congress go home and visit with their constituencies. On March 24th, the AHCA bill was pulled to avoid a failed vote when Speaker Paul Ryan knew that he didn't have enough votes to pass it in the House. But what does the future hold? Let me turn things back over to Anne to continue that discussion.
Thank you, Jean. As Jean mentioned, the AHCA was pulled the first week of March. However, that doesn't mean that there won't be continued effort put toward passing the AHCA or a version of it. And I want to take just a minute to talk about where healthcare payers or insurers are right now while things are in limbo. Overall, insurers are in a wait-and-see stance. The nation's health insurers are resigned to the idea that the Affordable Care Act will be repealed for the most part. In December, health insurers publicly outlined for the first time what the industry wants to stay in the state marketplaces. The insurers that I'm going to refer to now are members of America's Health Insurance Plan, which is one of two national associations of insurers. The second is the Blue Cross Blue Shield Association, which I'll comment on in just a minute. But in the meantime, the insurers who are participants of AHIP say that they need a clear commitment from the administration and congressional leaders that the government will continue offsetting costs for low-income people. They also want to keep in place rules that encourage young and healthy people to sign up, which, of course, as we've seen, is crucial to the stability of the market, the individual market. Insurers could decide within a few months whether to pull out of the state marketplaces for 2018. AHIP was a major force in the passage of the law in 2010 and is expected to be influential in its discussions with Republicans going forward. The Blue Cross Blue Shield Association, the other major trade group, has not yet said what it needs from Republican lawmakers to continue operating in the individual marketplace. The CommonwealthFund.org site, which is my favorite site on earth, has an article that outlines the administrative changes that can impact the ACA. That is, perhaps the ACA isn't appealed outright, but there are things that can be done from an administrative perspective, to contribute to undoing the stability that the ACA offers. The first is cut off the subsidies. One of the biggest threats to the ACA has been a lawsuit filed by House Republicans that could have ended cost-sharing subsidies that help people limit their out-of-pocket expenses. The 2014 suit charged that the Obama administration was unconstitutionally spending money that Congress hadn't formally appropriated to reimburse health insurers who were providing coverage to working poor policyholders. Last spring, a judge sided with the House Republicans but allowed the subsidies to remain in force pending appeal. With the new administration that is taking responsibility for the appeal, should the Trump administration decide to drop that appeal, it would be quick and easy and potentially crippling to the Affordable Care Act. And just a quick note that 57% of marketplace enrollees in 2016 had subsidies from the federal government. The second is remove the individual mandate's teeth. That is, the mandate can't go away without changing the law. However, the Trump administration can modify the teeth or the strength of the law by not having the IRS, for example, follow through on making sure that people pay, the people who choose not to participate in the individual market stop paying the tax, the fee. The third is to let states be looser in defining essential health benefits. The current administration can choose from a few paths for changing what the essential health benefits are. Changes that could weaken some people's health care, but also maybe nudge more insurers into the marketplaces. The federal government laid out and defined the EHBs, but a state's EHBs can be found in its benchmark plan. The fourth would be to redefine the essential health benefits. The administration could tweak the EHBs by broadening or narrowing the definitions of some of the 10 broad benefit categories, and this could be done through administrative rulemaking. The fifth is let states experiment more. States can apply for waivers to deviate from the ACA as written in some way. The idea is to enable experimentation at the state level to improve the system. States could pass laws that change their healthcare system and then apply to the federal government for the waiver. Alaska has already applied for a waiver to the ACA beginning in 2017, a waiver that would begin this year. And then the sixth would be to let the architecture crumble. It takes a lot of upkeep to keep the ACA running. The exchange websites need to work and people need to be ready to answer the helpline. But the administration could make a lot of that a lower priority and let the ACA system atrophy. In the first week of his presidency, in the first week of Trump's presidency, the advertising around the Affordable Care Act and outreach, the email notifications to people had gone to the site. Those things are no longer supported. There are two overall health policy strategies that we've been talking about directly and indirectly today. And those two are equity and efficiency. The two positions have different impacts on individuals when they experience significant health problems. The two positions also have different impact for low and middle income populations compared to those with high incomes.
Okay. Do you want me to take this one?
Yeah.
Okay.
You just had a note on the slide, I think, that I wasn't able to speak to.
Okay, sure. So one of the things that is important as we think about health spending and we think about insurance markets is the concentration of spending amongst a very small portion of the population. So this particular chart shows the cumulative percentage of total spending in the U.S. And basically it's demonstrating that the top 5% of spenders account for 60% of all healthcare spending, personal healthcare spending, and the bottom 50% essentially account for about 2% of spending. So spending distributions are highly skewed, and that creates issues for how we proceed in terms of thinking about either pooling risk or segmenting risk.
Thank you. I'd like to take a minute to talk about high-risk pools. We've touched on them briefly, and I want to take a deeper dive into what they are. Oh, no pun intended. High-risk pools are being presented by some Republicans as part of the solution to stabilizing the individual market. High uninsurance rates and lack of affordability for individual market buyers existed before the ACA, including in states with high-risk pools. Policymakers may be underestimating the number of Americans with pre-existing conditions who could be forced to purchase coverage through high-risk pools should insurers be allowed to deny coverage due to pre-existing conditions. Here's what we know. HighRisk pools were expensive, and they concentrate people with health conditions into a single pool and note that there are no healthy members to offset the cost of that pool. And then what happens, of course, is that out-of-pocket costs for enrollees are high and coverage in turn was limited. And administrators tried to limit losses and lower premiums by applying high deductibles and cost sharing. And from a personal experience perspective, that's challenging. In state high-risk pools operating before the Affordable Care Act, premiums ranged from 125% to 200% of average premiums in the individual market and covered only about 53% of claims and administrative costs nationally. 14 states had plans with deductibles of $10,000 per year or higher, which was higher than the current maximum $7,150 deductible for catastrophic plans in the marketplaces today. 30 states imposed maximum lifetime limits. Others had annual coverage limits as low as $75,000 per year. Utah had both a lifetime and an annual limit. And in 2010, the 35-state high-risk pools incurred $2.4 billion in total costs to cover 221,900 people, I should say. The U.S. Department of Health and Human Services estimated that up to 18 million people with pre-existing conditions were uninsured in 2010. If all of them had been covered by high-risk pools, the cost would have been $194.8 billion in 2010 dollars, with premiums covering only $103.3 billion. So states and the federal government would have needed to find $91.5 billion in additional funding to cover them all, much more than the up to $10 billion per year in federal assistance to states recently proposed by congressional Republicans. Let's take a closer look at reinsurance, which is designed to protect insurers from very high cost claims.
Very good. So in terms of reinsurance, right, that's a slightly different system for, again, dealing with high-cost claims, where we have a third party paying part of the insurance company's claims as soon as they pass a certain threshold, typically called an attachment point. Again, this type of system can help stabilize an insurance market and make coverage more available and affordable. It does kind of take a different approach relative to a traditional high-risk pool. Minnesota actually has been active, as well as other states, around trying to address the instability in the individual market by financing a mechanism to try to stabilize things via reinsurance and maintaining insurer participation in the state.
Thank you, Jean. Let's summarize some of the ideas that we've touched on today, that Jean and I have touched on today. The first is that federal health reform is designed to address concerns about cost and coverage. The Affordable Care Act is complex, and it's designed to do challenging things, achieve insurance-related policy objectives, cover as many people as possible for the lowest cost. Growing evidence of the impact of the ACA on insurers, providers, employers, and employers shows a mixed bag of results. Uncertainty is created by the political environment and is influencing market behavior, with longer-term implications to be determined.
Very good. Thanks, Anne. So we have about 10 minutes remaining, and we want to encourage you to send us a question if you have particular questions about the material that we've covered today. We do have a couple of questions that have been put forth thus far. I can go ahead, or Megan wants to, do you want me to go ahead?
Go ahead,
sure. Great. So Victor, you have offered a great question, which says the authors and the Dems readily agree that there are problems to the ACA. What are they, and what are the potential solutions? that could be a whole nother hour unto itself. I hope you're all chuckling out there at your desks. No, it's a very important question. And I think what strikes me as being the most important is that when the ACA was passed, clearly there were several types of policies put forth designed to address affordability and access and to promote competition, particularly in the individual market. I'll be the first one to say that I think that's been the much more volatile piece of the coverage expansion. What was key here was that these policies, these different provisions, were meant to interact with one another and to function together to achieve the result. And what we've seen is that there's been challenges brought forth because of some unanticipated selections, so different composition of risk pool that was anticipated. Most of the states that had high-risk pools put all of those enrollees into the individual market, so that increased the risk of that population. And frankly, premiums were set aggressively in some places and had to adjust over the years. So there's been a lot of premium growth, and I think that's created a lot of criticism. Now, of course, we're in a situation where, even if the Republicans' attempt at reform has been stalled, there are real challenges facing states and local markets around whether or not the market will remain or will it implode. And I think Anne hit on a really important point about insurers' behavior. And I would stress that uncertainty created in the political environment has made things very challenging as we look ahead. It's possible that simply the uncertainty created will induce insurers to behave in a way that could create real adverse selection problems for the market going forward. Anne, do you have anything else to add to that?
I don't. Just to reinforce the idea of that uncertainty is causing pause, and it's tough for insurers to know what they're going to do next in the short term as well as the long term.
Very good. Oh, we have another question. All right. States are also addressing budget challenges driven by Medicaid expansion. In some states, there is discussion about reducing funding. Between the federal debate and individual state remedies, what should provider organizations plan for in the next couple of years? Thank you, Mark, for submitting that question. Okay, I'll take a crack at that. And so I think that's an excellent point. Clearly, states are in very different positions from a budgetary standpoint. Those that have had stronger economies have been typically in better shape. But for many states, the Medicaid expansion is really where the dominant gains in coverage occurred. And even with, while the eligibility shifted and increased in those states that chose to expand, there were also many existing eligible Medicaid enrollees who signed up. And so the states are on the hook for a larger share of that. I think in terms of provider organizations, the evidence does suggest that at least that there was a shift from uncompensated to Medicaid, but as we know, Medicaid payment rates are still quite low relative to private kind of employer-sponsored insurance coverage, for example. So I think that there will be some increased cost pressure on that even with the newly covered, it's better than nothing, but the question is, for providers, will it be enough to break even on caring for those enrollees? I think going forward, just in general, we're seeing more anecdotes suggesting that the increased attention or media focus on premium growth and healthcare cost growth would suggest that we may be starting to have some more upstream discussions about why healthcare costs are as high as they are. And again, that will put providers in the spotlight for thinking about, and I hope to push faster and harder on payment reforms that emphasize value. Any additional questions from our audience at this point? All right.
All right. Well, thank you all for joining, and thank you, Jean and Ann, for your time and expertise that you shared. We will be sending out a survey, and we would love to hear your feedback, and please provide us with topics you'd like to hear about in the future. Thanks again, and we will hopefully you'll all join again this summer. Thanks.
Great. Thank you very much.